عظيم وأعتدنا لهم عذاب السعير وللذين كفروا بربهم عذاب جهنم وبئس المصير إذا ألقوا فيها سمعوا لها شهيقا وهي تفور تكاد تميز من الغيظ كلما ألقي فيها فوج سألهم خزنتها ألم يأتكم نذير قالوا بلى قد جاءنا نذير فكذبنا وقلنا ما نزل الله من شيء إن أنتم إلا في ضلال كبير وقالوا لو كنا نسمع ونعقل ما كنا في أصحاب السعير فاعترفوا بذنبهم فسحقا لأصحاب السعير إن الذين يخشون ربهم بالغيب لهم مغفرة وأجر كبير وأسروا قولكم أو اجهروا به إنه عليم بذات الصدور ألا يعلم من خلق وهو اللطيف الخبير.
So, Alhamdulillah. So, today program is arranged by Iqbal Relief. So, let me introduce. You already know what the Iqbal Relief is, and Alhamdulillah, if I talk about the Sacramento MCF Muslim community of Folsom is the biggest sponsor for Iqbal Relief. Alhamdulillah. But just for the sake of introduction, that why we are doing this program, it's a part of our programs. Alhamdulillah, MCF is collaborating with us on the Sakina Trashal Home. But the Sakina Trashal Home is only the one area in which the Iqna Relief is working. Other than that, we have 6 different programs that we are running all across the USA. And Alhamdulillah, during the last 5 years, we have served almost 5.1 million people across the USA. Through the different programs. Like we have the hunger prevention program, and almost 56 food pantries are serving across the USA in 46 cities right now. And we have the 26 shelters. We don't call them shelters, these are the homes that the Sakina, like the one that Trashal Home is Sakina Trashal Home. And we recently opened one in the Bay Area, which is called the Afia Trashal Home. And similarly, we have almost 26 Trashal homes all across the USA, which are providing the services for the sisters that are looking for the help. And today's program is the part of the Muslim Family Services. So Alhamdulillah, we are also taking care of all the emotional needs of the people. We are not only in the field of serving the people like the hunger prevention program, like back to school program, but we are also looking for the emotional well-being of our Muslim community. And it is like a taboo in our Muslim community when we talk about the mental health. We don't take it as a serious matter, but living in this society in the US, it is the statistic that 1 out of 5 in the US adults, they are suffering from the mental health. And it almost takes, the statistics show that it almost takes 10 years for a person to realize that he's suffering from the mental health. And unfortunately, when we talk about the Muslim community, we don't take it seriously. We think that it is a matter which is related to that somebody is suffering from the mental health. Normally, we take it that he's not a guy that who is a religious guy, or maybe he's not a guy that who is close to the religion. Maybe this is the one of the reason that he is suffering from the mental health. Other than that, there are other many reasons due to which we are not taking it serious. But believe me that this is the one aspect that we need a serious consideration. And specifically, I'm talking about our youth that are suffering from this mental health. So today's program is bringing an awareness about the mental health. And we have with us Dr. Faisal. Let me introduce him that our Dr. Faisal is a psychiatrist by profession, and he is a subspecialized in child and adolescent psychiatry. He completed his general psychology residency training at the University of Missouri Columbia program and child and adolescent psychiatry fellowship at the same institution. So he's certified by the American Board of Psychiatry and Neurology, and he has worked in various mental health settings, including outpatient clinics, inpatient, and consultation license services in the past. So today he's giving us the awareness about the mental health. So after his presentation, and Dr. Jawad, I will ask Dr. Jawad to come over, inshallah. Brothers all come. Okay, so these both are over here. So these are our brothers, and these are also the ICNA members of the General Assembly. And Alhamdulillah, they are also engaged in the Dawa programs too. So I would request Brother Dr. Faisal to give us the awareness about the mental literature. And we have the question answer session after that.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. So, couple of things. First of all, the mental health. This it's growing. The problem is growing, and every household been affected in some way, or form or shape. It's so vast when we think about mental health. Still a taboo in our society to talk about, but things have changed. The new generations, the coming generations, are growing up in the American schools, and that's where they are exposed to a lot of mental health issues, which we didn't back home. So it seems like in past years, so I've had so many people from our community approached and requested help. It almost seemed like we are tone deaf about this issue. So this is just one of the effort to get people at least the basic awareness. The whole idea was to create more awareness so that people have better understanding. They have better understanding. They reach to better treatments. Anyway, so this is a larger presentation, but I tried to squeeze it in a smaller one. So it's sort of was supposed to be a workshop, but we concised it a little bit. So just a general outlook of that presentation. To stay with me on this one, and we're gonna do it in two parts. So So it's a two-part presentation. So we can start with growth and development and then mental illnesses. Why growth and development? Because in any sciences, if you want to know about abnormal, you have to know about normal first. And if you don't know about normal, you can't really define abnormal, right? So if you can have basic idea about growth and development, then we will possibly be able to have better idea. So the growth and development goes like this. The children are not just miniature adults. The children are not just small adults. They have a very different personality, different characteristics than adults. So a lot of times when we are dealing with the children, we are looking at them or we're dealing with them with our adult lens. And their world is very different from the angle they see the world. So they're not just miniature adults. And the child development actually is a very complex interaction between genetic potential and the biological capacities and nurturing environments. Three things, right? So nature and nurture. Nature, what they are born with, the genetics, and then what they are exposed to, the nurturing, and then their own capacities play a big part. So someone can run really fast, someone can think and is a thinker, someone is good at reading. There are different capacities which plays a part in children development through all these three traits. Again, in order to know abnormal, you need to know normal. Stages of life, just a brief overview, just to give you an idea of how this we develop, of how our life goes. So the psychologists have defined and divided the life into few stages. They start in infancy, about 2 months or 1 year of age. You see this is the stage of extreme dependency, means not just extreme dependency, but also urgency of needs. So when the child wants milk, he wants milk right then and there, can't wait, can't see the arguments, can process that if it's not available, then you just stop crying. So extreme dependency comes with the urgency of needs. This always this is very important part, which I'm going to talk about a little bit about this later on. So extreme dependency, first of all, you're extreme dependent on things, and then urgency of need, that you kind of need it right away. Low frustration tolerance, very low frustration tolerance. So when they get frustrated, they start crying right away. So they don't wait. No consideration of others, right? They don't consider the 3 months old, 4 months old, they don't care who's around them. So and then there's a social smile. Every parent I know now, the grandparents come in and the child smiles at them and they say, "Oh my God, he loves me," or this is a social smile which has nothing to do with the personal interactions. Is the way the child interact with his environment. So it's good that the parents and grandparents feel that way, but this is a very natural process of social smile. It's actually an indicator of a much larger problem. If the child does not have a social smile, then that's a problem. Because that means that we are talking about neurodevelopmental disorders, and we'll talk about a little bit about later on. Anger and sadness by 2 months of age. So by 2 months, your child is able to. So the first emotion which develop in a human being is actually anger and sadness. Can you imagine that? The first emotion the child experiences. The first emotion the child experiences, start to feel the emotion. When we have this variety of emotions now. So you feel sad, happy, mixed, irritable, but you name it. But the first emotion for the child develop is anger and sadness, and it stays with us for us of life. But just imagine, this is the most primitive. What does that mean? The first developed means the most primitive, right? So think about a plant, right? So when it grows, the most primitive stage is in the pot, right? That's the weakest stage of its life. The big tree, you see, the weakest stage, right? And that's the most primitive, emotion, anger and sadness. So we'll talk about it later on as well. Babbling, they start to say words a little bit, making sounds. Babbling means making sounds, but they're not necessarily words. And then here comes a stranger anxiety. This is something which, we all struggle with. The child start crying and a new person comes into the room. That's the stage about 8 to 9, normal, complete normal. There's nothing wrong with your child. If it's crying with strangers, it's basically stranger anxiety, which is very necessary for him to develop the object permanence and be able to recognize people later on. Then the social referencing, 8 to 12 months. That's where the whole year they start the social reference. What does social reference mean? That if I'm happy, that the child will able to feel happy. If I'm smiling, the child will know that I'm smiling, and then he will smile and reply back in the same way, same fashion. So, so that's where you see that we start reading them stories and so on and so forth. And social referencing is why I'm talking about this, because when we think about autism and we think about all these neurodevelopmental genetic disorders, that's what's lacking. Social referencing is lacking. The child does not develop social referencing at the age of 1. So social referencing is that the child's ability to relate to the emotion of the other, right? And then separation anxiety emerges. 10 to 18 months, completely normal. Separation anxiety means the parents leave or caregiver leaves, they start crying, they start getting really uncomfortable. And that is very, so I tell you a story that one of my friends, the child, when we were back in residency, the child, when he was young, the child was born, we all celebrated, we used to live together in London, so we all celebrated his birth, and then he grew up with us for a few months, and then he went back to Pakistan. And then I went back to Pakistan after a year, and I met with this guy, and I tried to hug him, and he pushed me away. This is, he's completely forgotten. And that's the important part, that the separation anxiety, try not to hurt children, try to hug them unnecessarily if they are pushing you away. This is the normal separation anxiety which they have, and they emerge, and it goes away as well. Then embarrassment, they are very sensitive to embarrassment by the age of 15 to 24 months. Before that, no, they don't care usually. But then 15 to 24 months, you start to notice that they get embarrassed. And then it grows further on. Then you get the age of preschool, which is between 2 to 5 years old, very robust language development. So your vocabulary goes from 1 year, 50 words to 200 words, and then goes to 4,000 words. Can you imagine how it jumps from 200 words to 4,000 words just within a year? They just rapidly language development. They start to have self-control and free will through mastery of bodily function. So when they start toilet training is not just a toilet training just for the cleanliness, but also give them control, give them a sense of control over their bodies. And the children who are having difficulty in toilet training, they usually have they have the problems temperaments as well. So one of the sign of conduct disorder, which is a childhood antisocial disorder, one of the symptoms is actually bedwetting and enuresis. So you can connect the dots that the child is not toilet training and for a certain age, then there are problems. Ability to separate from caregiver transiently, but then they also start to identify themselves with the same-sex parents. They are more close to the sex they have, the boys with fathers and mothers with girls, the girls with mother. They start to realize their role with the same-sex parents. And then the most fantastic thing about this age, from 2 to 5, is the magical thinking, the egocentricity. Again, egocentricity, the whole world revolves around you. There's nothing else exists. So whatever happens in your environment is because of you. So that's called egocentricity. So everything happening in this world is because of me. It's related to me. That egocentric in this age from 2 to 5, they are pretty particular about that everything happens for me, and then magical thinking, that they don't have any bounds to their thinking. So they would create castles in the air and they would have wild imaginations. And that's where the stories, and that's where we read them stories. And why is it important? Because in our Islam, the parenting, if you are aware of these stages, you can actually teach them according to these stages. So between these two magical thinking and then the parallel play, they start to play parallelly. But does that mean that when you combine, when you join 2 1-year-old, don't expect them to play together. They will play their own thing. But then, around that preschool age, they start to play together a little bit, and then cooperative play, playing together in a group setting, like a combined play, would be 3 to 5 years. So before 3, it's very hard for to combine them in a game or in some activity. They usually play paddle. So if you leave them somewhere, they would play paddle. And then 3 to 5, they start to play more in a cooperative way. Another one, the school age, that's the most important age. We're talking about 5 to 12. That's make or break stage. 5 to 12. Greater exploration, creativity, building, and accomplishments. That's what all it matters. That the child at this age is looking for one thing: validation from their environment. If they get validation, they develop trust, confidence, and personality. If they don't get validation, then you see all these people with having difficulty making decisions in their lives. They have the low confidence, low self-esteem. That's all it originates. Most of it originates here, 2 to 5. What does validation mean? Validation means that, okay, my child comes home, got 3rd in class, and he tells me, Dad, I got 3rd in my class. And I said, oh, good for you. And I got on my iPhone. Don't care. So good for you, right? So didn't get the validation, lack of validation caused severe problem. But then there's a second stage, a further stage to it, that the child comes home, the dad, I got 3rd in class, and says, well, you could have worked harder, you could have easily come first. That's called invalidation. That's worse, right? Invalidation harms us. And in our community, what can I say? You all know about this, what happened in our community, in our parenting. We're never satisfied with our children. So that's that's one issue there. But just remember the age. You can be unsatisfied with the parent when you're 15 or 14, but just remember 5 to 12 is the make or break area. You gotta validate every little success of the child. You gotta validate every little accomplishment. That's why we have so many in schools. this age, we have so many awards and, trophies and stickers. It's not very early. You can start getting stickers at, kindergarten at age 5 and 6. You can start getting stickers, little stickers. Everything has a reward to it. That reward is basically a validation from your environment. What happens if you don't get validation? We talked about that. Basic logic builds on this age as well. Basic logic, conservation. So if I see if I put water in a tall glass and a small glass, but the amount of water is the same, they can tell that the amount of water is same depending on how they look, regardless of how they look. So that's called basic conservation logic. Around adolescent age, that's what we deal with. That's where things start to pop up. That's where things start to hurt as a parent, right? 12 to 19. This is the age where before that you somehow manage things, but then 12 to 19, that's where things start to hurt if things are going wrong or something happening. So puberty in girls happen around 8 to 13, boys from 10 to 14. These are normal ranges. Just remember, these are normal ranges. So physical changes. So if a boy is, they mature later, and very obviously you can see that, right? Maturity goes way back, but 10 to 14, girls mature faster and earlier. Physical changes happen, identity formation happen, and then parents are wrong until proven otherwise. Okay, so see the drastic change. You see huge change going from validation, everything my mom and dad says right is right, until proven otherwise, to change to suddenly age 12, everything changes except my parents are wrong until proven otherwise. They suddenly start questioning you, suddenly start pulling up their phone and showing up that you're wrong. Your vocabulary is wrong, your accent is wrong, you're this and wrong, that wrong. Basically, that's where it starts, the adolescent age. They suddenly becomes of their own identity. They start to separate from their parents, and then they start to identify themselves. And we identify ourselves with our peer group, not our parents. Otherwise, my father would be, I would be like my father, my child would be like me. So in order to create diversity, Allah subhanahu wa ta'ala has created that stage where we develop individually in our own capacities, and most of it is identified by our peer group. Advanced cognitive abilities, deductive reasoning happens in this age, 12 to 19. They're able to see the right and wrong, and they're able to see moral development happens between 12 to 19. They're able to differentiate right and wrong. And this is the age which we say in Islam, this is the youth groups come into play, the mentorship come into play. This is the age group targets. The identity, what can go wrong at this age? Well, identity crisis, right? So if you think about the previous stage, we're talking about validation and lack of validation, and that causes confidence and assertiveness and all that. This stage is all about identity. So if the child is having problems and doesn't have a peer group, let's say, right? Socially isolated child, does not go out, does not meet with people, does not have a peer group, can't identify with anyone. So that's the problem. He's going to get identity crisis, and it's going to be a problem. That's what we're seeing a lot. You can see that that whole storm brewing on the horizon with this I don't want to say it, but it's the whole thing we are dealing with right now in schools, and the bathroom and all these issues are popping up just because we had so much isolation for the children. They stop going outside, they stop interacting, they stop spending more time in virtual worlds and gaming, that they are not really getting there. They're not developing the identity of their own. So that's why they start questioning their identity so much. So that's the end of the growth and developmental part. We'll have question and answer session later on, but this is important because every stage of life, as you say, we talk about adolescent, it goes all the way to end of the life. I omitted that part because for the sake of the concise nature of the presentation. So the next part of the presentation was the mental illnesses, what goes wrong. So first of all, let me tell you something. The mental health, for some reason, we still, in deep down, and probably it has a lot to do with our upbringing and the culture we grew up in, is that we still feel that brain and mind are two different things. They're not. So in simple words, brain is a biological organ. You can touch and feel and see. And mind is something in the cloud out there, right? So for some reason, your mind go crazy, but your brain is intact. That's not true. Brain and mind are both the same thing. So what happens is that if something can go wrong with your kidneys or your liver, it can heart, something can go wrong with your brain too. Accept it. That's the reality. Something can go wrong. How difficult it is to understand that if my kidneys can have a problem, I can have kidney stones, I can have heart attacks, I can have all these issues with my body, other organs of the body. Something can go wrong in the brain. Why not? Right? Just like Allah subhanahu wa ta'ala tests us with illnesses, and that one of the illnesses is mental health illness, right? So it just present differently. That doesn't make it less problematic, right? So the way we divide mental illnesses is 5 categories: mood disorders, anxiety disorders, substance abuse disorders, psychotic disorders, and neurodevelopmental. There are far more categories, by the way, but for the sake of this presentation, just a general awareness of the things which we deal with everyday life and how our households, or children, our grandchildren, or our friends, sons and daughters, and we see these problems around us. These are usually the more common problems we see. That's why we concise this presentation to this. So for that, mood disorders, I want to ask Dr. Arif to come and present the rest of the slides for the mood disorders.
Assalamu alaikum. So Dr. Faisal presented the normal variation, like and how we develop, our brain develop, our emotion develop throughout the years. And he mentioned something very significant, that the puberty, when the puberty hits, puberty has a significant effect on our emotions, and based on the gender, puberty age is different, but based on the gender, the way hormonal changes affect our emotions, that is also very significant, and we need to keep that in mind, that girls, females become more prone to emotional illnesses as soon as puberty hits, and the difference is almost 2:1. That the depression, bipolar illness, or any sort of mental health illness, the risk of having mental health illness females is far more than the boys. So the first thing that we have heard about a lot is major depression. Major depression, it's very common. It's more common than we think of. Like, we all get depressed, as Dr. Faisal mentioned in his part of the presentation, that our emotional regulation is based on multiple factors. Our genetics is part of it. Our that is nature, that how, and then the nurture, that like the environment people grow up in, that also affects our emotional regulation, because from the start of our birth, as soon as we come into this world, we start learning from our environment. And in that environment, we learn that how, as Dr. Faisal mentioned, that at the very initial stage, the mode of communication for the child is crying. And the response which comes from the mother or father is that as soon as the child cries, parents respond by try to understand whether it's like colic, is the stomach hurting, or the child needs milk or food. So these things, the child is learning from that as well, how to respond to it. But in a lot of households, and especially in the Western culture and the culture we're living in, the nuclear family system is kind of breaking up. Parents are not available. Parents are doing drugs. and our parents are dealing with their own problems. A lot of time they're not available to the child. So these kind of problems start at a very early age for the child, and then by the time they hit puberty and the distance from the parental thinking and as during the teenage when parents are around. So a lot of emotional problems start to come up. So major depression is one of the very it's one of the most common diagnoses we see in our clinical practice. A lot of people take treatment for major depression. Just to give you an idea, the most medications people take on a regular basis are blood pressure medication, diabetes medication, asthma medication, cholesterol medication. The fifth or sixth most commonly used medications are antidepressant medication, and because of the taboo, mental health has people are not very comfortable discussing, so that's why we don't know. We can discuss a blood pressure medication very easily to a stranger on a bus stop or in our office that I'm taking blood pressure medication. But if somebody is taking mental health related medication or major depression is hard to discuss, even sometimes to our loved ones, like people who are very close to us. So the symptoms start very early, and as Brother Naveed said in the beginning, it takes almost 10 years when people start to get treatment and realize that I need professional help. It's the leading cause of disability in the United States. Disability means that people who are not able to work and government is paying them a monthly stipend to live a decent life. Symptoms of major depressive disorder in a nutshell is sadness, low energy level, poor attention concentration, problems with sleep. Sometimes people sleep a lot. For some people, they sleep less. Appetite changes is also very common. Major depressive disorder can also present with psychosis. Pregnancy is extremely difficult for women because there are massive hormonal changes which can affect emotional regulation of women. So during pregnancy, those hormonal changes affect women, and they can get severely depressed to the point that they can have thoughts of harming themselves. Postpartum depression can also occur, and soon after the pregnancy, again, there is huge shift in the hormones and neurotransmitters which regulate human emotions. And at that time, again, like for us as men or husband, it is very hard to understand the emotional challenges women are going through in the postpartum period. So it is very important. The young guys who are not married and the guys who are married, that women go through extreme challenge in managing the emotion during the postpartum period. It is seasonal affective disorder is another thing that another diagnosis which people deal with, that some of the people for them summers are hard, for some of the people winters are hard, and there are different treatments for that, and I'll come to that. And I think like in this presentation there is some description of that. In like clinical characteristic of juvenile depression, irritable mood, dysphoria, inability to enjoy favorite activities, social withdrawal, blame, worthiness, guilt, suicidal preoccupation, normal sleep patterns, fatigue, diminished ability to concentrate. So treatment, moving on to treatment, accurate diagnosis definitely requires some professional help. Psychologists, psychiatrists can help with this diagnosis. Antidepressant medication, as I mentioned earlier, these are one of the most commonly used medication in the Western culture after diabetes, blood pressure, cholesterol, and asthma medication. These are one of the most commonly used medications. The emotional regulation occurs through neurotransmitter. Those neurotransmitters play a very important role in that how we react to the situations, how we react to the stressors. One of the most important neurotransmitter which helps us with the emotional regulation is serotonin, and depletion of serotonin is considered to be one of the major cause for the depressive disorders. And because adequate amount of serotonin is required to feel the happiness, depletion of serotonin is considered to be the cause of depression. And the medication we use for depression actually increase the level or increase the level of serotonin in particular parts of our brain. So there are different kind of antidepressant medication, almost close to 20, and not that like one is better than the other. There are a lot of factors which genetic factors, which determine that which medication can work better for me. There are two people, for example, dealing with depression, and both are coming from the same ethnic background, same gender, same height, same weight, but it is quite possible that with the same medication, one is getting the best response and the other person is getting the worst side effect because there are so many genetic factors. So it is trial and error in the treatment. So if any one of you or anybody you know is having side effect from one medication, it is always a good choice, like better choice to try another medication, another antidepressant medication, because that person might respond to that the other antidepressant medication. Most common side effect are GI related: nausea, diarrhea, headache, vomiting. 10% of people get these side effects, 90% of people don't get it, and usually these side effects go away after a few days of use. DMDD is disruptive mood dysregulation disorder. It's a new diagnosis, and I think Dr. Faisal wanted to mention this because this is the diagnosis which is from the age of 6 to 10, when kids are throwing out temper tantrums and going through emotional dysregulation. That's where this diagnosis come, and outbursts in kids from age 6 to 10, average 3 or more times per week, mood between outbursts nearly every day, mood dysregulation between outbursts nearly every day, most of the day, persistent irritability or staying angry. Irritability is observable by others, parents, teachers, and it is in all settings, at a school, at home, in both of the settings. Patients not had 3 or more consecutive months without the symptoms, and usually these disruptive behavior continues to go on for almost a month. The next diagnosis for the mood disorders is bipolar disorder. Bipolar disorder, just as the name says, bi means two, polarity means extreme. For example, polar bear, extreme white bear, or North Pole, extreme north, South Pole, extreme south. So two extremes of the mood. So we talked about major depressive disorder. Depression is down mood, depressed mood, low energy level, poor attention, concentration, sadness, wanting to stay in a dark room, don't want to see anybody, not enjoying the activities. So on the lower side of the mood. Another extreme is mania. Staying too happy, not sleeping, having loads and loads of energy only after sleeping 2 hours, starting too many projects, not able to complete it, talking loud. In depression, people talk slow and with a low tone and low volume. And mania, people are loud, they're talking a lot. In depression, we have thought blocking. In mania, We have racing of thoughts. Sometimes people get hyper-religious, sometimes people get hypersexual, people impulsively spend money. So two opposite set of symptoms presenting in a person at different times. Again, it's usually the symptoms come to the surface and diagnosis is made in late 20s, early 30s. A lot of time in childhood, bipolar disorder is misdiagnosed as ADHD as well. Bipolar disorder is one of the most commonly it has the highest heritability coefficient, means that it's transferred to the next generation more commonly than other mental health diagnoses. Treatment, again, mood stabilizers and low dose antidepressant medications. We can go into the details, but mood stabilizers are a little different than antidepressant medication, and antidepressant medication sometimes in bipolar disorder patient can cause mania, manic-like symptoms, and that is also an indication that person may have bipolar illness. Psychotherapy, again, for depression as well as bipolar disorder, that helps. It's hard to find therapists, but therapy plus medication management is really helpful. Bipolar disorder can also have psychotic features, and antipsychotic medications are also very helpful. Do you need to talk about autism as well? Okay, so but I'll just quickly go over anxiety disorder. So most prevalent psychiatric disorder in the general population is with patients' functional impairment, distress, and high utilization of medical care services. Anxiety has two components. So one is psychological, that something bad is going to happen, but I'll be able to talk in front of a lot of people. What if I'll go to the office? How people are going to react to my dress, my appearance. So anxiety can have one component is psychological, and the second component is physiological. That heart rate goes out of control, muscles get tense, numbness around the mouth, sweating on the forehead. So psychological stress, and in response to that psychological stress, biological or physiological things happen. The diagnosis, and so anxiety disorder is the bigger umbrella. And under that umbrella, we have generalized anxiety disorder, panic disorder, and PTSD. Dr. Faisal is going to talk about PTSD, but generalized anxiety disorder is, in simple terms, it's anxiety or staying anxious and apprehensive about normal daily life activities and thinking of the worst case scenario. For example, like I go to the hospital every day for the last 15 years or 18 years, never had a flat tire, but I'll start thinking about that how I'm going to get to office or hospital tomorrow morning. What if I have a flat tire? And I'll stay worried about it the night before, the point that I am not able to sleep. So we start thinking, we start staying worried about a situation which is least likely to happen, but we start thinking about it to the point that our sleep is affected and we are not able to do we are not able to function properly in our daily life. Panic disorder is a set of like 12, 13 symptoms. That heart rate goes out of control, sweating. I think you have the list here. Recurrent unexpected panic attack about which there is a persistent concern, series of intense episodes of extreme anxiety, typically last for 10 minutes, may last for 5 to 30 minutes, can present without agoraphobia. But a lot of time when people have panic attacks, they think they're almost having a heart attack, and they end up in the hospital and emergency room, and in the emergency room, they're being told that your EKG is normal, your cardiac enzymes are normal, and it comes without any warning. And the heart rate was out of control. So panic attacks happening more frequently, and there is a specific criteria that they happen 2 to 3 times a week, 2 to 3 times in a week, and they're happening for 1 to 2 months. That's when the diagnosis comes up. Social anxiety disorder is about going in, having anxiety about going into a social situation in which person is exposed to unfamiliar person, and this exposure provokes anxiety and fear of embarrassment and often panic attacks. The patient avoids anxiety and avoid anxiety provoking situation, resulting in marked distress that people stop going out of their houses. So next one is PTSD, post-traumatic stress disorder. Very common, especially in our communities, when people are coming from war-affected areas. So Dr. Ahmed can talk about it.
So, thank you, Jazakallah, Dr. Arif, for a wonderful presentation on a short notice. MashaAllah, he did an amazing job. So, post-traumatic stress disorder. Now, why the post-traumatic stress disorder is talked about so much. So, a couple of things I wanted to clarify first about trauma. So, trauma is not just limited to war. Trauma, anything which can occur to a human being, which which directly affect the integrity of the person, it's basically a trauma. And we used to have this old concept about PTSD that, okay, you have to be either raped or being a victim of an abuse or being being in a war that you can get this PTSD. That is out the door now. It's out the window. The qualifying trauma has expanded tremendously over the years. So think about a child. For child, a trauma can be a simple maltreatment or a neglect can be perceived as trauma. A lot of times bullying in school is a trauma for a child, right? All these issues which affect a child's development and affect make them feel horrible about themselves. This is a trauma, and it has the same consequences of it, right? It's a very complex somatic, cognitive, affective, behavioral effects, which happens in the body. So think about this. One of the major psychological effects of a trauma is that it sucks the trust out of you. So the people who are traumatized, they can't trust their environment. Now, think about this in this terms. So if you have a default, right? So whenever you move from default, you are going to have a problem. So let's use an example. The example of a car. The default of the car is to go straight. And if something comes in front of us, you steer the wheel, right? That's how the car should run. But if I mess up your car and the default of the car becomes steer away constantly, and you have to make an effort to go straight, how difficult the driving is going to be. Now you can go to short distances, you can go to Walmart, Walgreens, that's fine. But if I ask you to go to San Francisco in that car, a 2.5 hours drive, you'll notice some changes in you while you're driving. You'll notice that you're on the edge of the seat, you have to keep your hands on the steering wheel all times, you can't relax. You notice that there are so many slow drivers just there to annoy you, everything starts to get on your nerves. The potholes, the condition of the road, the state is terrible. I'm living in a wrong state. Everything becomes so personal. Start getting under your nerves. And by the time you reach San Francisco, you're miserable. When you left Sacramento, you had plans to go to these Pier 39 or whatever. But by the time you get there on that misaligned car, you don't want to do anything. You just want to sleep in the car. You're so tired and fatigued just by driving. Now you didn't carry the car on your shoulder. You were sitting in a very comfortable seat. But just for the fact that 2.5 hours in this drive, you constantly have to make sure the car goes straight, exhaust you completely, wipe you out, and also make you very, very irritable. very, very reactive to your life. You start shouting at people, you start honking at people, right? And every now and then you try to drive fast and try to get ahead of the traffic and just break the law. Let's get out of this traffic somehow. Our bodies, our humans have a default too. And what is the default? Remember the first stage I told you? Trust, that if I'm hungry, my mom is gonna be there for me, right? If I'm gonna do something, my dad and mom are gonna validate my things, right? That's a default, that everything is going to be okay until proven otherwise. Now what's gonna happen? Trauma is going to, so the default is everything is gonna be okay, like that car, straight. If something comes up, I'll deal with it at the time. I'm not worried about, I'm not anticipating it. So I leave the home in the morning, I'm not worried about, something bad is gonna happen. Now, trauma changes that default. Now the default becomes something bad's gonna happen, no matter what. And I have to make sure that my car goes straight, that everything is gonna be okay. Exactly like that car. 10 times worse. Why? Because two things. Number one, on the driving analogy, the drivers, the slow drivers, the potholes, they're not related to you. They have nothing to do with you. In real life, the people we deal with are your brothers, sisters, fathers, daughters, mothers, wives, children. Everybody is related to you. So whatever you feel about them is going to be very personal. It's going to affect your environment, right? So that's why we see that PTSD, one of the common symptom complex PTSD is a lot of anger, irritability, and relationship problems. So lots and lots of relationship problems. Such a high divorce rate in veterans. Huge because of that anger issues and irritability issues. That's a very common phenomenon. But anyway, getting back to this change of default, right? So think about it in the car's analogy. You just take the car to the mechanic, you'll change the alignment, and you'll be fine. But in human, it's not that simple. You have to have some treatment. We'll talk about that. Just the woman twice as likely to have post-traumatic stress disorder as men. That doesn't make. By the way, I just want to clarify. That doesn't make women. If the woman have emotional vulnerability early, it doesn't make them weaker in any sense. It makes them actually more sensitive. And nowadays, I think we are lacking the sensitivity thing. Can you agree with that, right? So right now, we are lacking the empathy altogether. We are like robots. People are killing themselves on computer and streaming, and people are encouraging them to do that online. We're lacking empathy. So there's really nothing wrong with having a little bit more emotionality. It makes us human. It makes us superhuman, actually. Right? So women are blessed to have more emotions because that helps them raise the child well, So but they are also the gifts come with some curse as well. So basically the PTSD risk is higher. And then this is the older research. About a third of the individuals reported PTSD, but it's far more than that. Very good chances of remission if you get the right treatment. Who's at risk? So I use this example. Two people go, you think about so many people get traumatized in Syria and Palestine, and children are exposed to so many things. Not everybody is developing PTSD. So means that there's things which decide who's going to get PTSD and who's not going to get PTSD. So we kind of figured that out. The risk factors for developing PTSD. So if you are traumatized, humans are extremely resilient creations. So not everybody is going to get PTSD. Don't get scared. The child is exposed to a trauma, it doesn't mean that he's going to get PTSD. There are risk factors, right? What are the risk factors? If he already have some anxiety and depression genetically or biologically, then yes, he's at risk of developing PTSD, is traumatized. Female gender, we talked about that. Lower socioeconomic status is linked within some studies, is linked with higher risk of PTSD, and it could be a cause and effect. Because lower socioeconomic has a lot more challenges in parenting as well. Minority status, that's more geopolitical. Dose of trauma, what does that mean? How bad the trauma is, right? So if you're exposed to a huge trauma, of course, the risk is higher for developing PTSD. Perceived life threat, if your life is directly jeopardized, in the trauma, that increase the risk of PTSD as compared to someone you just witnessed a horrible accident on the road versus you are part of that accident. Of course, common sense, right? Presence of numbing, that's also a risk. If you get numb about everything, by his personality, you don't really feel anything and you just suppress everything, you're at risk of PTSD, developing PTSD. Lack of social support, of course, subsequent life stressors are also. So if you're constantly in a stressful environment, your chances of developing PTSD is much higher. What are the protective factors? So this is important actually, and this is on the face of all the psychiatrists and the researchers who don't believe in God and don't believe in religion. They are the one who did the research, not us. They found out that spirituality and religion is one of the most important protective factor against PTSD. See what, so when we look into it, our religion actually protects us from PTSD because you believe that there's somebody out there so that trust that I'm not alone. There's somebody up there who's always going to be taking care of me, who's always going to be there for me. So that's spirituality, but also the resilience factor. That this is highly genetic resilience, friends and families. That's a very significant factor. High school degree, college education is a protective factor. Older age at the time of trauma. Common sense, right? If a child gets traumatized or adults get traumatized, two different presentations. But definitely higher socioeconomic status. Again, positive parental relationship is very important to understand. Positive parental relationship is based on validation. We talked about that already. Validation is important, right? So that's part of positive parental relationship. Having an identity as a survivor as opposed to be a victim. Two people go to the war to a trauma, two people come out of trauma, and one come out as survivor, one come out as victim. What is the difference? The survivor is going to take responsibility for his future actions and will do his best to change the course of his future. And the victim will blame the world for his trauma and would not take any responsibility. He'll just give up and just, do whatever he wants to do. So completely two different trajectories. So the person who comes out as a survivor has a completely different trajectory than the person who comes out as a victim. Good problem solving skill, genetic factor, of course, it helps protect it. Treatment, psychotherapy treatment is 70% therapy, 30% medication. Always the rule, 70% therapy, 30% medication. What kind of therapy? There's trauma-focused cognitive behavioral therapy. There's, I'm bringing in the TSCBT, trauma-focused cognitive behavioral therapy, EMDR, and then they recently introduced dialectical behavioral therapy as a modality for PTSD as well, which has been very helpful. And then there's a brand new one, which we won't call brand new, but for the past 5 years, we're talking about mindfulness treatments, which are part of the dialectical behavioral therapy as well. Medications, again, Dr. Arif talked about medication. We treat it like depression, mostly anxiety and depression. SSRIs are the preferred choice, and because of their favorable side effects. But we use, depending on what kind of symptoms are predominant, there's a lot of aggression and mood dysregulation, we use mood stabilizers. If there's just only depression, anxiety, we use SSRIs. For nightmares, we use alpha agonist, and that helps with the nightmares, completely take away the nightmares, by the way, it's amazing. And if there's a lot of aggression, then of course we use antipsychotics as well. Further moving on, really quick, psychotic disorders. Psychotic disorder, I wanted you to spend a little bit of time on the psychotic disorder, given the time we have. The psychotic disorders basically is if you think about psychosis, means that it's a detachment from the reality. Simple as that. Detachment from the reality. Huh? Okay. So think about psychosis as detachment from the reality. All right. So there are certain terms I want you to understand before you actually learn about psychosis. So there's delusion, which is basically, this is a static entity, means it's a fixed false belief, right? So I believe that I'm son of God. That's a fixed false belief. I believe that I own the world. Fixed false belief. I believe that the FBI is after me. Fixed false belief, right? That there's no truth to that. And I'm not making that up just to, be cool. Hallucination is an active entity. Illusion is a fixed entity, and hallucination is an active entity, means something is happening. All right, something is happening. So either you're seeing things, hearing things, are feeling things in his game. These are called hallucinations. The difference between delusion and hallucination, delusion means just belief. Hallucination, something is happening, active symptoms, right? So either you're hearing voices or you're seeing things which aren't there. Again, detached from the reality. If I'm seeing someone who's actually there, it's just normal seeing, right? Paranoia, that term is important. We use it a lot. There's an English word paranoia and there's a psychological word paranoia. Paranoia means that's an unwarranted delusional belief that one is being persecuted, harassed, or betrayed. And not just the fear, but also reaction too. Paranoia includes the reaction which comes with it. So you actually become very, very anxious and you have physical symptoms along with it. Schizophrenia, so what the different types of psychosis in psychiatry, I'm not going to go into a lot of detail. Schizophrenia is one which you have these symptoms out of nowhere. At the age of 17, you start having sign of delusions and hallucinations, start becoming religious and start reading the scriptures, and you start, or just one example, hyper religiosity, but you can start getting FBI is after me. Around 9/11, there's a lot of people who start getting that way, and rightly so. But then after that, when things improve, they continue to be that way. COVID caused a lot of paranoia too, and these are the things. So if you get over it, that's great. But if you don't, then it becomes out of proportion. Again, detachment from reality. If I'm worried about COVID, it's real. It's a real threat, right? But if I'm checking everything and I'm really feeling that somebody is injecting the COVID in me, that's a paranoia, right? So schizophrenia, delusional disorder. Again, the difference between schizophrenia has both active and passive symptoms, delusion and hallucinations. Delusional disorders, you just have delusions, you don't have any hallucinations, you don't have any active symptoms, you just have this false belief that you are the prophet. Let's put it this way. Schizoaffective disorder, when you add the mood symptoms to it, then you have schizoaffective. Now, the next one is the very important one. And this is what the youngsters were sitting, a lot of questions about marijuana, a lot of questions about cannabis. Huge issue right now. We have concluded, American Academy of Child and Psychiatry, several studies have been done, proven fact now, that if you use cannabis an excessive amount, more than a gram a day, for consecutive 20 to 30 days, you are at an extremely high risk of psychosis. All right, extremely high risk of psychosis. We get at least 10 to 15 admissions every month, just cannabis-induced psychosis. All right, so it's a huge issue because it's a highly addictive substance and it's legal. That's the worst part, right? Nobody in the legislature thought about it, that what's going to happen from age 17, 18 and less if you legalize it. And now everybody's in. And our Muslim youth have a question. Every single forum I've been to, or I've seen the same question come up. And I think Imam Amir is sitting here, a lot of youth must have asked him too the same question. What about cannabis, right? It doesn't really intoxicate you as alcohol does. What if it's legal? Is it haram? Is it halal? Think about it. It's causing psychosis, huge amount of psychosis, right? Again, treatment, medication, for psychotic disorder treatment, medication, psychotherapy, and psychoeducation. These three modalities always go along with every psychiatric illness, but there's a difference in psychotherapy with each condition, different types of psychotherapy. That's why you have to go to a therapist. Now, the last part of this portion was neurodevelopment. Why I'm choosing neurodevelopmental disorder, the last part, and one of the things which I emphasize on is because we have absolutely very, very zero idea about this condition. Unfortunately, it's so prevalent. We don't know the extent of it. We think that the child is just aloof, or the child is just, and we just don't realize how autism affects us. So one example, common, so it's just remember the ASD or autism spectrum disorder is a range. So from very mild to very severe. Very mild is the person is Albert Einstein, right? Madame Agatha Christie or Leonardo da Vinci, all thought to have Asperger's disorder, autism. Elon Musk, known autistic, right? Very high functioning, awesome guys. And then all the way down to someone who can't speak, can't go to party training, can't function, can't work, right? Huge spectrum. And the spectrum means range. from high functioning to very low functioning, right? So it can be a gift or it could be a curse, depending on where you are in the spectrum. So common example, a typical example, a 3-year-old child pays little attention to his parents or adults. Remember my earlier talk about that developmental delay, social referencing? These are the early signs. You can catch up with the year 1 year or 2 years of age. You can actually catch. The average age of diagnosis is about 3. But, that's where the children mostly come into the radar at the start is age 3. And in our community, it's way beyond that. Actually, we keep stay in delusional state that the child is just my child and there's nothing wrong with him. And it's very difficult to accept that my child has autism, and my heart goes out for all the parents who feel that way. But you are doing not a service to your child if you're not getting him diagnosed and not getting services, because of the fact that the whole learning part of the autism, these things can be cured, these things can be learned, that some of the deficits they have actually can improve if provided that they have the services, the right the social skill training, if it's provided right, that can improve the social functioning of the child. The occupational training can actually help with their tantrums. They can help with the triggers. So a 3-year-old boy pays little attention to his parents, repeats certain words in a stereotypic manner, fascinated with the running water, watches fans, rotating wheels, odd little child in a corner in every party. You see someone would seem different, seem odd. Now, I'm not saying that being different odd is autistic, but at least raise some red flags, right? If you try to talk to a child and the child is looking in the north and completely oblivious to your presence in the room. I mean, I literally been to the houses of some of my acquaintances, and I go to their house and for a party, and I see the child completely oblivious of the people around him, putting blocks in, and I talked to father. I said, "Is it okay?" I said, no, he's just like that. It's just fine. Oh, he hugs us. Hugging you is not actually uncommon. Children with autism can hug their parents. That's okay. So differential diagnosis. What are the common confusion we have when we even think about differential diagnosis, right? So the child can have a hearing loss. That's why he's completely oblivious of the other's presence in the room, that he can't hear anybody very well, right? So if you're talking to him and he's not looking at you, probably hearing loss as well, right? That could be. So you need to exclude all these things. Childhood onset schizophrenia is a very huge issue, but very, very rare. We are talking about 0.001% population. That's really low. Population would suffer from that. Mixed receptive expressive language disorder. They have a certain type of language disorder, dyslexias and things like that. They would look like they're autistic, but they're not autistic because they preserve their social function, right? And psychosocial deprivation. This is an important one. Think about all the refugees and all the people with trauma-laden places, all the people who are exposed to extreme trauma and poverty and all that, and they become numb. And they become just numb. They can't feel anything. If you talk to them, they will look autistic. Really, literally, the huge trauma can do that to us. So what do you do? Evaluation, please take them to the doctor, get them evaluated. Historical information is more important to sit down with the parents, actually find out how the child will grow. You remember our first discussion? We talk about social referencing. Was the child was really started saying babbling at that age or not? Child was actually having social referencing. These are the questions you ask when in an evaluation. What I told you in the first part of my presentation, the social referencing, the normals. You check on the normals, and then developmental psychological assessment. Then there's tools you can do, which helps you, get things more clarified. And then the psychiatric examination, and then medical evaluation is important because there are sort of a lot of medical conditions which can present like autism, like lead poisoning is one of the conditions which can actually look like autism spectrum. So a lot of genetic disorders can present with autism as well. Therapies, treatment, educational therapy I talked about. This is the point. I'm going to end this here because we're running out of time. Delay. The worst thing you can do to your child, well, one thing is this guy, is already suffering. And the one thing you can is the delay in treatment. Delay in treatment because the ability to learn will close its door around 12 to 13. So whatever you can teach them around that age is what they're gonna have rest of their lives. So if you teach them, if you get them the social skill training, if you get them the occupational training, therapy, physical therapies, speech therapies, early, you are actually giving them the tools for the rest of their life. By 12, 13, they will start saying no to everything. Okay, that's what usually the patterns are. They're gonna stop learning. So the window of opportunity is very, very short. Now, there's no medication for treatment, just to mention that, just a disclaimer, there's no medication for autism. But we treat the things which comes with autism. For example, anxiety, aggression, tantrums, right? All these things we treat with medication, same way that we treat any other condition. So this is the last slide, one example of bad parenting. And this is, yeah. Thank you very much.
So Jazakallah khair, Dr. Faisal and Dr. Jawad. So if you have any questions, so we have only 1 minute inshallah. Because we have to. Yeah, please.
Well, education, that's for sure. But remember, this is what I said initially. We're living in a very different world now. Our children don't underestimate our new generations. They are very much in line with what's happening around them. So it's not much an issue now in newer generations as it used to be in the past, in older generation, first of all. Number two is that if somebody is from the past, and for our generation and still believing jinns and bad jinns, or demons or all that, then education is the only way. Awareness. This is one of the reasons why we are here for awareness about situations, right? So, yes. Jawad?
Just quickly want to mention one thing that like jinn and possession, like that's part of our belief. Like this is something which can happen. So that's why like family history is really important. Like if it is consecutive, like if it's happening from generation to generation, multiple people in the family are being affected. So family history is really important, and convincing people can bring them to a doctor is one thing, but in the family, if something like that is happening, I always tell people that, okay, we are going to go to the sheikh, we are going to go to, we are check those avenues as well. But taking medication is one of the avenues. So do not oppose that. Walk the walk with them. Have them go to wherever they want to go, but also try to convince them let's go there as well, but I will go there with you, but you go there with me. So try to be the partner, not to be the person who's imposing what they want to do.
So Jazakallah khair. So we're concluding over here because the time of Isha is here. So Jazakallah khair, and we have refreshments outside. So after the prayer, you can take the refreshment, inshallah. Jazakallah khair.
This is the one presentation